I'm H.S. Kim from Seoul National University Hospital, Korea. I'm really glad to share the first results of Host-Br Rct. This is my disclosure. The bleeding risk is a very important prognostic factor after PCI as a thrombotic risk. Thus, Academic Research Consortium proposed the HPR definition. Patients having annual major bleeding 4% or more. That is defined by here the major criteria as well as two minor criteria such as age and NSAID usage. Guidelines strongly recommend physicians to stratify your patients based on Acc.25 definition, but no previous study has evaluated specific duration of depth stratified according to Acc.25 BR. A general recommendation is 1 to 3 month depth for high BL versus 3 to 12 month depth for non-high BL, low BL. However, we do not have evidence based on Acc.25 criteria which duration of depth would be optimal. Host-Br Rct is the first randomized study to stratify patients according to BL based on Acc.25 criteria to test different duration of depth either in high or low BR population. In high BR stratum, we randomized them into 1 versus 3 month depth. In low BR stratum, 3 versus 12 month depth. We checked 3 co-primary endpoints that were assessed by hierarchical order. The first component is NACE. The second, MACE. Third is BARC type 235 bleeding at 1 year. Hypothesis is within each stratum, the shorter depth being non-inferior to longer depth for the first and second component of co-primary endpoints, and be superior for the third component. 1,600 patients are required for high BR stratum. We assumed NACE as 1 year as about 9%. We set non-inferior margin, absolute risk difference 2.7%. That corresponds to hazard ratio of 1.3. 3,300 patients are required for low BR stratum. NACE was assumed at 1 year as 4 or 5%. We set non-inferior margin as the absolute risk difference as 1.5%, corresponding to hazard ratio of 1.3. This is study organization. We enrolled nearly 5,000 patients and stratified them into high BR or low BR stratum based on Acc.25 criteria. For high BR stratum, we randomized them into 1 versus 3 month depth. For low BR, 3 versus 12 month depth, and checked 1 year outcome. This is actual flow of the about 5,000 patients first stratified into high versus low BL and randomized into 1 versus 3 month or 3 versus 12 month depth. We completed 1 year follow-up in over 99% of the patients. Here's baseline profiles of high BL, age 73, female 1/3, stable 40%, ACS 60%, among them STEMI 5%, DM over half, CKD about 1/3, previous PCI about 20%. Very severe profile patients. Clopidogrel depth was mainly used in 90% of these patients. Anticoagulant users about 17%. Here's baseline profiles of low BR stratum. Age 63, but 10 years younger than high BR stratum. Female, 20% less, compared with 30% in high BR stratum. Stable, 40%. ACS, 60%. STEMI, 10%. DM, just 1/3. CKD, rare. Clopidogrel DAPT was mainly used in 75% of patients in this low BR stratum. Here are primary endpoints. The first component was 1-year NACE in high BR stratum. That was 18.4% after 1 month DAPT, 14% after 3 month DAPT. Absolute risk difference was about 4.4%. The confidence interval is shown here, crossing preset margin plus 2.7%. Non-inferiority was not met. Thus, we didn't continue the statistical analysis for the second or third component. Second component is 1-year MACE. We just described the result. 9.8% after 1 month DAPT, 5.8% after 3 month DAPT. Absolute risk difference is about 4%. Hazard ratio confidence interval is above 1. The third component is any actionable bleeding in high BR stratum. 13.8% after 1 month, 15.8% after 3 months. 2% difference. Hazard ratio confidence interval cross 1. Here are primary endpoints of low BR stratum. The first component, 1-year NACE, 2.9 after 3 months, 4.4 after 12 months. Non-inferiority is well met. Thus, we move on to second component, 1-year MACE, 2.2, 3 months, 2.3, 12 months. Non-inferiority was well met. Then, third component, any actionable bleeding in low BR stratum, 7.4% after 3 months, 11.7% after 12 months. Hazard ratio is 0.63. 3 months was significantly better than 12 months in terms of any actionable bleeding. Here is each component of clinical outcome of high BR stratum treated with either 1 month or 3 month DAPT. 1 month DAPT was associated with higher incidence of cardiac death, ischemic stroke, target lesion revascularization, and lower incidence of minor bleeding, BARC2, not major bleeding. Here is each component of clinical outcome of low BR stratum treated with either 3 first 12-month DAPT. 3-month DAPT was associated with low incidence of hemorrhagic stroke, low incidence of minor bleeding, BARC2, or major bleeding, BARC3. Limitations, open label study, the use of specific PY inhibitor was left to the doctor's discretion. Thus, clopidogrel was mainly used because most physicians in AP regions well acknowledge that key RCTs of ACS and AMI in loading stations have shown that clopidogrel is superior to ticagrelor, leading to clopidodapt as the standard and most frequently used regimen, although ticadapt is recommended for ACS in the Western world. The findings may not be generalizable in all ethnic groups, but optimal duration of clopidodapt for East Asians may be applicable to ticadapt for Westerners. This is a very important topic for the future research in the Western world for white or black people. In conclusion, for high BR patients, 1 month DAPT did not meet non-inferiority to 3-month depth for NACE. 1-month depth was actually inferior to 3-month depth for NACE and MACE at 1 year, while there was no significant difference in any actionable bleeding. In low BR patients, 3-month depth reduced any actionable bleeding without increasing NACE or MACE as compared with 12-month depth. Overall, 3-month would be the optimal default duration of depth after PCI in general to meet the balance of thrombosis and bleeding. Thank you very much for your kind attention.